It is a real pleasure to participate in this symposium on debridement because, as I hope I will show you, debridement is one of the most important components that you can incorporate into your wound care to correct the molecular and microbial imbalances that are making major contributions to preventing the wound from healing. So in the next about 15 minutes, I'm going to really try to set the stage for both Andy and Trudy to tell you how to translate some of this basic information, the basic biochemistry and microbiology into more effective wound care. So what I'm going to do is very quickly review for you the sequential phases of normal wound healing because I want to point out the beneficial effects of controlled inflammation and protease activities that are part of the normal process of wound healing. But then I'm going to strongly contrast that with the link between chronic inflammation caused in most cases by a bacterial biofilm component that eventually leads to elevated levels of protease activities and reactive oxygen species that destroy the proteins that are essential for healing. And these are extracellular matrix proteins, growth factors, and the receptors. Because in the concept of wound bed preparation, what you're really trying to do is rebalance this level of proteases into a range that is compatible with healing. And one of the challenges that you face in terms of trying to reduce the bacterial bioburden to levels that are compatible with healing is dealing with this newly understood concept of bacterial biofilms in chronic wounds. And so I'm going to take a few minutes and show you instances and examples of why bacteria, when they are in this protected biofilm community, develop such high tolerance to antibiotics, antiseptics, and disinfectants that normally kill planktonic bacteria very, very fast. But the good news for you is that this concept of biofilm-based wound care that is beginning to take traction both in the States and in Europe is really only a refocusing of the basic concepts of wound bed preparation that you already practice well. So it's not a new concept, it's just understanding why debridement is such a critical component of wound bed preparation. And the two key things to emphasize about biofilm-based wound care within the context of wound bed preparation is the importance of debriding the biofilm away, because as I'll show you, we don't kill it very well. And the second is to prevent the bacteria from reforming the biofilms, because as I'll show you, it only takes a matter of a few days for bacterial biofilms to reform on the wound bed surfaces. And I'll show some new data about the effectiveness of debridement with a monofilament-based pad, the DebraSoft pad, on mature biofilms using what I think is our best in vitro model of wound biofilms, and that is a pigskin explant. So again, just very, very quickly, because you're very familiar with this, there are four major phases of wound healing in skin. These are hemostasis, inflammation, repair, and remodeling. And the hemostasis phase, as you know, occurs immediately after an injury to the vascularized tissue. The two key things happen here is the fibrin clot forms to prevent us from hemorrhaging to death. But the other key factor is that the platelets degranulate, and they release substantial amounts of preformed active growth factors and cytokines, and they really serve as the stimulus to bring in the first wave of inflammatory cells, the neutrophils, which come in within about 24 hours. Now, normally inflammation will peak after about 5 to 6 days in a skin incision in the absence of continued bacterial stimulation. And then it spontaneously regresses, and that allows the wound to move into the third phase, the repair phase. And as you know, this is when that provisional fibrin matrix in the wound bed becomes replaced with a more collagen and proteoglycan-dominated matrix. So that's really the scar tissue. In addition, new vessels, new capillaries will form through the process of angiogenesis to reverse the ischemia that has occurred through the initial injury. And finally, the epithelial cells will migrate across the wound bed once the fibrin has been modified enough to allow the epithelial cells to recognize a collagen and fibronectin-friendly matrix with their integrin receptors. The myofibroblasts will also form as a conversion from fibroblasts, and they will grab that provisional matrix and contract it with their actin filaments. Now, when we think of the epithelium resurfacing the wound, we think the wound's healed. But as you know, that really only moves the wound into the fourth phase of the remodeling, in which that irregular scar matrix that was deposited as rapidly as the fibroblasts could make it becomes slowly broken down and replaced with a much more normal histological architecture of collagen fibrils. But for us today, the key in these four phases of wound healing is to understand this issue of inflammation, because data from multiple laboratories has now, I think, conclusively shown that a majority of the chronic wounds that you deal with are stuck in a chronic inflammatory phase, usually now caused, we understand, by the presence of bacterial biofilms. And so your challenge when you're dealing with a chronic wound is to move that wound out of the chronic inflammatory phase into the repair phase. And one of the best ways to start that is through debridement of planktonic and bacterial biofilm and allow the inflammation to come to within normal ranges. Now, I'm going to tell you how bad chronic inflammation is, but I want to re-emphasize for you the importance of controlled inflammation, because without the controlled actions of neutrophils and macrophages, we would not heal wounds well. In fact, if we take animals and deplete their inflammatory cells, their wounds heal very, very slowly compared to animals that have intact immune systems. And we see similar things in patients that are immune suppressed. And of course, two of the major activities that these inflammatory cells undergo is they engulf and kill the contaminating bacteria through the generation of reactive oxygen species, such as superoxide radical, hydrogen peroxide, or hypochlorous acid, which we all know is bleach. So basically, our inflammatory cells bleach the bacteria to death that they have engulfed. But equally important are the release of proteases, particularly the matrix metalloproteinases, or MMPs, and another class of serine proteases, elastase. And as this diagram shows, they are really doing the initial enzymatic debridement of the damaged matrix that occurs when an injury was created in the matrix. And so through the controlled action of proteases and the controlled generation of reactive oxygen species, the contaminating and colonizing levels of bacteria are rapidly controlled, preventing the conversion into a biofilm-dominated matrix. So that's what's supposed to happen. What happened in these patients who developed these four major kinds of chronic wounds? Because remember, all of these wounds started as an acute wound. So why did they not move through those four phases to a repair? And we now believe that the major unifying hypothesis of the core concept of wound pathophysiology shares this type of a sequence in which in each of those acute wounds that failed to progress, there was some form of repeated tissue injury and ischemia, whether it was the insensate diabetic foot ulcer that couldn't feel when the patient was walking, or whether it was the paraplegic that couldn't feel the pressure ulcer on their bony prominences. Whatever happens, eventually that acute wound becomes heavily contaminated and colonized, and as I'll show you, some of those planktonic bacteria persist long enough to convert into the biofilm phenotype. And it is the combination of the planktonic and biofilm bacteria that stimulate the initial chronic inflammatory response. And we can measure that by show that by measuring the levels of pro-inflammatory cytokines in wound fluids and biopsies, such as tumor necrosis factor alpha, or IL-1 and IL-6. And these pro-inflammatory cytokines do exactly what they're supposed to. They draw in the neutrophils and macrophages and activate them. And those inflammatory cells do exactly what they're supposed to. They engulf and kill bacteria through generation of reactive oxygen species, but they also secrete these proteases to debride the enzymatically debride the damaged tissue. But unlike the beneficial things that happen when inflammation persists for about the first 5 days, if a biofilm is formed, as I'll show you now, those bacteria are very difficult to remove, and they cause chronic inflammation that results in elevated levels of proteases, sometimes hundreds of times the concentrations that you find in an acute healing wound. And those proteases are not perfect. They have what biochemists call off-target effects. And unfortunately, they will begin to degrade other targets such as growth factors in the receptors, extracellular matrix proteins, and so forth. And that results in impaired cell proliferation and migration, which you see clinically manifested as an acute wound that has moved into a chronic wound phase. So your challenge in correcting this pathophysiology amplifying cascade is, first of all, to remove the start of this cascade, to remove the level of planktonic and biofilm bacteria, to reduce the amount of activation that flows through this diagram.